So good evening again, our dear friends, CEC. Tonight we have a very interesting webinar. The European Association of Cardiovascular Imaging has released a document in 2021, like 1 month ago, actually discussing the main modalities for imaging for myocardial viabilities, indications, and techniques. Myocardial viability has always been an important question before revascularization, and especially before attempting very high complex techniques for revascularizing some kinds of CTOs, bifurcations, the importance of side branches, whether this ischemia will improve the mortality or only is symptomatic or even does not improve any symptoms or mortality. So actually viability is an important guide that guides us through the decision making towards our patients with ischemic heart disease. Tonight, we are glad and honored to have two very eminent imagers, Dr. Ahmed Farid, his lecturer and consultant at Suez Canal, and Dr. Alexander Nosikov, his consultant also from Sofia, Bulgaria. And Dr. Alexander is a very eminent figure in the field of imaging. Dr. Ahmed Farid will take the first half of the webinar discussing the role of the butamine stress echo, and then Dr. Alexander will highlight the importance of the other forms of echo, strain, deformation, contrast echo imaging, and so on. So Dr. Ahmed Farid, the floor is yours now.
Good evening, everybody. I would like to thank you, my dear friend, Dr. Mohammed, for the invitation, and all the CEC team for giving me the opportunity to talk about this interesting topic about the assessment of myocardial viability. It's, as you had said, it's important for decision making, and it's always had been an area of debate along the past years, which modality and what modality to use, and either to use it or not. And I think you are planning to do a series about the multimodality imaging, about the viability assessment. Today, I think we will talk about the echocardiography, and my talk will be about the role of the butamine echocardiography in the assessment of myocardial viability. Do you see my screen right now?
Yes, Ahmed.
Okay.
Yes,
okay, so my talk will be about the role of the butamine stress echocardiography in the assessment of the myocardial viability. And as we had said, that would be based on the most recent article that had been published in 2021 about multimodality imaging for the myocardial viability by the ASCVI Association. But before we go through the technique, we will ask some simple questions to be clear what we are looking for. So the question is, what is viable myocardium? And viable myocardium, the word viable, it's meaning of alive. So viable is alive. But what we are looking for in the ischemic cardiomyopathy patient, it's not the viable itself, it's the hibernating myocardium. And the hibernating myocardium, it's alive, so it's viable, but it has a reduced resting function due to chronic ischemia, and it will recover after revascularization. And contrary to the stunning is alive with also a reduced resting function, but it has a spontaneous recovery without revascularization. So the term viable myocardium is very broad and cover even the normal myocardium is called viable myocardium, inducible ischemia, partial thickness of the infarction, hibernating myocardium, stunned myocardium, and myopathic myocardium, all are called viable myocardium. And we should note that the term viable implies nothing regard to the contractile status. So you may have a viable myocardium, but it's not contracting. And you may have a viable myocardium that is well contracting without any wall motion abnormalities. So you have to discrepancy between those terms. It all starts with the head of the acute ischemia, and the acute ischemia results in myocardial damage. And the myocardial damage may cause either an irreversible damage with a complete scarring and complete death of the myocardium, or it may result in a reversible or a viable myocardial damage, which can be translated into either a stunned myocardium or a hibernating myocardium. The stunned myocardium is a delayed recovery of regional myocardial contractile function after acute cut of blood supply, then it has reperfused again. So it's like a knockout to the myocardium. So the contractility had stopped for a little bit and it come again because of the blood flow had been maintained again. The examples of the stunned myocardium are the myocardial infarction aborted by reperfusion, either pharmacological or by PCI, or after an episode of unstable angina, or after ischemia induced by the stress testing. So you have a normal function, then you have an acute ischemia with the regional wall motion abnormalities, then the blood flow is restored again, and then the myocardium gradually returns to its normal function. So the stunning, it may have some time course of the myocardial stunning. It doesn't happen immediately that it regains its function again. So the dysfunction may persist for hours or even as long as 6 weeks post-insults. That's why the assessment of the systolic function for judgment of using an ICD, like if you use an ICD in ischemic myopathy, should be delayed after 6 weeks because of the resolution of the myocardial stunning at all. But what about the hibernating myocardium? The hibernating myocardium is a state of contractile dysfunction in viable myocardium with chronic ischemia. It's viable but underperfused myocardial tissue and mostly regain functionality after revascularization. And as you can see from the image on the right side, this boxer that has been knocked out due to repeated hits, that's what happened with the hibernating. It's due to chronic reduction of the resting perfusion or repetitive stunning, repetitive cutting of blood coming back, and or a mixture of both. So the hibernating myocardium, it's what we are searching for. It's akinetic myocardium. It's an ischemic syndrome and an improved function after revascularization. And this is what we are looking for by searching for myocardial viability in ischemic cardiomyopathy patients. So let's move on to the topic of our lecture. So the use of low-dose vitamin echocardiography for detecting a viable myocardium. The idea of the test is the test relies on detection and the changes in the wall motion abnormalities by 2D echocardiography. And the viability assessment can be considered in segments that are dysfunctional. In the rest, it's either akinetic or dyskinetic at rest. So you are not doing a viability for a segment that's showing hypokinesia at resting state. So you are doing a viability test or the vitamin stress echo for segments that show akinesia or dyskinesia at rest. And the improvement of the regional dysfunction is usually accompanied by improvement of the global dysfunction. The global LV function is improved in the particular segment itself. And this is very important to see by the vitamin stress echocardiography. And this is one of the most powerful points in this modality, as we will talk later about this. The low-dose vitamin is the preferred pharmacological test agent for viability assessment. It has direct inotropic effect on dysfunctional cardiomyocytes. But why we are using the vitamin itself? The vitamin by nature is a synthetic catecholamine that has a predominantly inotropic effect when used at lower doses, less than 10 microgram per kg per minute, via its effect on the beta-1 adrenergic receptors on the heart. So in the low doses, you are using only the inotropic effect of the drug. But if you go into higher doses than this, it will have a chronotropic effect. It will increase the heart rate, and this will result for assessment of the ischemia. Another important point that the vitamin is very short plasma life and less than 2 minutes. So it must be administered at continuous infusion, and it's just you need to stop the infusion, and within a few minutes, all the effect of the vitamin could be resolved. So, as we had said before, that with increasing the dose of the vitamin, you are activating the B2 receptors, and you getting the chronotropic response, not the inotropic response. So how you could image a patient if you are planning to use a low-dose vitamin echocardiography, you are using the classic views you are using with the standard echocardiography. You're using the transthoracic images of the left ventricle from the apical 4 chamber, apical 2 chamber, the parasternal long, and the parasternal short axis. And images of the left ventricle are acquired at 4 stages: the baseline, at low dose, the peak dose, and in recovery. And you are getting an image similar to what you are seeing on the left, on the right, and the right side. The images are displayed in the rest, the low dose, the peak dose, and the recovery images. Using this software is very important for direct comparison for the changes that occur all through the test, from the baseline to the peak response. So this is very important to use this software. You cannot use it just the regular imaging screening that you are using in the regular studies. So how would you infuse the vitamin to a achieve this, you are using a protocol for the assessment of the myocardial viability. You are using the low dose test starting from 2.5 or 5 microgram per kg per minute and increasing up to 10 microgram per kg per minute at 3 to 5 minutes interval would be sufficient. And indeed, at the dose of 7.5 microgram per kg per minute was found to have the highest accuracy for predicting viable myocardium. So again, you are starting by the 2.5 and wait for 5 minutes, then go up for the 5 minutes, 7.5, 10, and you may need to go a little bit higher to the 20 microgram per kg per minute to detect the biphasic response, as we will explain later. So what is the definition of the low dose of the butomin echocardiography? As we had said, the increase in the heart rate of 10% compared to the baseline is considered a low dose. If it increased more than 10% of the baseline, this is considered to be a little bit higher dose. And it's usually accepted that we all say that the low dose is achieved by 10 microgram per kg per minute. So then recovery, and when you should image your recovery images, when the patient should be monitored during the recovery until his heart rate returns within 20 beats of the baseline heart rate, the wall motion abnormalities return to what that had been in the baseline, and the patient is asymptomatic without any symptoms. So when you should terminate your test, if you are starting the test and there's some alarming features that you should terminate the test regardless the finding you have found. If the patient had reached 85% of the maximum age predicted heart rate, new or worsening wall motion abnormalities develop, significant arrhythmia, and this is very important because the butomin by nature is an arrhythmogenic. If the patient became hypotensive, more than 20 millimeter mercury drop from the baseline blood pressure, or severe hypertension, or intolerable symptoms occur. But there are some contraindications to do the test, like the severe symptomatic aortic stenosis, uncontrolled hypertension, decompensated heart failure, uncontrolled arrhythmia, acute pulmonary embolism, acute aortic dissection, acute myocardial infarction, and acute myocarditis. All of these are contraindication to the butomin stress echocardiography. You need some requirements to do the test properly. You should have a machine with sufficient probe for the patients. You should have a digital image acquisition system, and preferably to be a quad screen view like we had shown before. Blood pressure cuff and stethoscope, echo beds, workstations, ergonomic for the sonographer, and emergency equipment. And this is very important, including a portable defibrillator and oxygen masks, because complications may occur and you should be ready to handle these complications well. You may also need a contrast agitator machine if you are going to use the contrast to see the myocardial borders, as my friend Dr. Alexander will say in his lecture. So let's come to the important part for the assessment or the interpretation of the findings from the test itself. And I can safely say that the bigger danger associated with the butomin stress echocardiography is misinterpreting the data obtained, because the butomin is really an operator dependent, either in the acquisition or the interpretation. So the main enemy of the butomin stress echocardiography is misinterpretation of the data. The American Society of Echocardiography recommend that viability assessment include improvement of at least 2 myocardial segments in the same vascular territory. So to say this is a viable territory, the viable vascular territory, you should have at least improvement in 2 or more myocardial segments in the same vascular territory. So what are the kind of response that you get if you go through the test? You may either have initial improvement and persistent improvement until the end of the test. This is considered viable. You may have initial improvement with the low dose and then deterioration at the end of the dose or with higher doses. This is called the biphasic response or the viable ischemic myocardium. Or you may have no improvement at all, and this is called the scarred tissue, no improvement of the segment at all. And this is for more clarification of this. As you can see from this is a systolic still image frames. Systolic frames, you can see from the baseline, there is no contractility. With the loose dose, there's some contractility. With the higher doses, again, there is no contractility again, and in recovery, there's no contractility. So this biclassic, this is a biphasic contractile response. So the biphasic response, as we had said, at low doses, you have a hibernating myocardium that will augment due to inotropic stimulation, and in higher doses, it became ischemic, and there is deterioration of the wall contractility again. And the biphasic response appears to be the most predictive of posterior vascularization viability. And the biphasic response has a specificity of 89% and good sensitivity about 74% in predicting the functional recovery after coronary revascularization, while the specificity is lower in cases of sustained improvement. So if you have a biphasic response, this is more specific and more sensitive than the initial improvement or the sustained improvement alone for detecting the improvement after revascularization. Also, the number of dysfunctional but viable segments per patient directly relate to improvement in left ventricular ejection fraction. So if you have 3, 4, 5 segments that improved, that will have an impact on the improvement of LV systolic function with the viability test and expected to improve after revascularization. So in the patient requiring at least 4 viable segments for clinical significant improvement of left ejection fraction. So you may have 2 segments that improved. So this is by definition, this is viable. But this will be translated into improvement in ejection fraction after revascularization? Not sure, but if you have 4 or more segments that tend to have sure improvement of the ejection fraction after revascularization. So if you have 1 to 4 segments, that has a prognostically significant improvement. But if you have 4 or more or 5 segments, you will have a functionally significant with improvement of left ventricular ejection fraction. And this is a paper had been published by Bax at the JAC at 1999, showing that the 4 segments is the cutoff value for the improvement of the ejection fraction more than 5% after revascularization, if you can see this by the vitamin stress echocardiography. But you can do it in a more quantitative way for the assessment. As we had said, that the main enemy of the dobutamine is the interpreter or the operator. So the test interpretation is done by at least a level 3 myostaff level echocardiologist and include evaluation of the global and the regional left ventricular systolic function. So you are looking at the wall motion and you are looking at the LV systolic function, both at the same time. And you are using the wall motion score index. As we all know that you can give a wall motion score index that we're doing with the rest, giving the normal segment 1, hypokinetic 2, akinetic 3, and dyskinetic is 4, and the aneurysmal you're giving 5, and then you calculate the wall motion score index at each stage. And if you have an improvement, then your score will going to decrease. So the more the decrease in the wall motion score index, the more viable you have. And this is the 16 and the 17 model segment that you are using to calculate the wall motion score index. And this is the vascular territory in each of the myocardial segment that you should use. I think all of you are aware of this. And this is example of the interpretation of the numbers. In the patient A, he had a resting score of 2.76. So this is a relatively very big infarction. And this is usually associated with severe systolic dysfunction. But at low dose dobutamine, we have noticed that the wall motion score index have decreased to 2.53. So you have 4 viable segments. But in the patient B, you can see we are starting with a resting score 1.8, which is a little bit better than the patient number A, but with the low dobutamine, it's still the same. So you have 0 segments that is viable. So this is another way for more quantification or objective assessment of the segmental motion score by the dobutamine echocardiography. But be aware when interpreting the segmental motion analysis by echocardiography. Its own depend on the visual assessment of the endocardial technique. So you should be aware of the translational motion from the surrounding segments and the tethered segments. You should analyze segment by segment. That's why you are using the 4-chamber, 2-chamber, parasternal long and parasternal short to be able to visualize all the myocardial segments. Be aware of the basal inferior a little bit hypokinetic compared to the other myocardium, so they don't deceive you. And honestly, comment on image quality. If you don't see a segment, please say you don't see the segment. It's if you have a poor endocardial definition or you are getting this from an off-axis view and etc. So you are looking when doing a test for the wall motion and the wall motion score and the wall motion improvements and the left ventricular ejection fraction, both at the same time. But it's not the only benefit of using the dobutamine. You can even more. You can even assess for the secondary mitral regurgitation, the functional mitral regurgitation or the ischemic mitral regurgitation. And the indication for adjunctive mitral valve surgery in patients with ischemic MR undergoing CABG remain controversial. And no approach currently predict in which patient ischemic mitral regurg will resolve with revascularization alone except the dobutamine. And this is a very important point for using the dobutamine for in patient with significant or patient with borderline mitral regurgitation that you want to make a decision either to do surgery or it will improve with revascularization alone. And supposedly the reduction in the ischemic MR caused by improvement of LV contractility during the stress might predict a beneficial effect of revascularization on ischemic debutant stress echocardiography, and this reduction is associated with improvement of regional wall motion abnormality of the posterior wall. So this is mostly the improvement of the mitral regurgitation occur when the segmental motion abnormality at this will be in the posterior wall, but in the anterior wall it usually doesn't show that significance. If the mitral regurg changes by a grade or more, it's called a dynamic MR and should be mentioned clearly in the results of the test. And even more, you may have the ability to assess the local aortic stenosis, which is associated in this patient. This patient have an impaired systolic function, and you may need to know if you're going to tackle this aortic valve or not. So this is a very advantageous added value of the debutant stress echocardiography, but this is beyond the scope of this lecture. But you should be aware that if you have a patient, you need to assess it. So your choice is going more to the debutant stress echocardiography. So there is some advanced techniques that help you making this, making the test more sensitive and more specific, like using the color kinesis, using the tissue Doppler, using the strain and straight rate imaging, using the curved M mode, using the 2D speckle tracking, but yet these are not standard practice. Until now, the standard practice is using the 2D assessment of the segmental wall motion abnormalities. But so there is some advantages of using the debutant stress echocardiography, like it's good validity, wide availability. There is lack of ionizing radiation. It's not like using the SPECT or using the nuclear scanning. It's friendly with implanted devices, so it's not like the MRI. It's helped with the assessment of MR dynamicity, which is very important as well. I said before, it has the presence of adequate acoustic window. It's a very under for using this technique, especially if you have female patients, obese patients, smokers. All of this may hinder visualizing the endocardial border in a clear way. And also the arrhythmogenicity with the butamine is a lot, but it's less occurring with the lower doses of the butamine. So after all of this, is it valid? Can we use it? Can we rely on the numbers that we coming from it? All we had said it's just an assumption, but without data, you are just another person with an opinion. So let's check, is it valid or not? It starts all with the prognostic value of the myocardial viability recognized by low-dose butamine in a paper published by the American Journal of Cardiology in 2003, which mentioned that had included 425 patients, which is a big number, with severe LV dysfunction, and they do for them the butamine stress echocardiography, and they noted defined myocardial viability with improvement of more than 0.4% of full motion score index, and the only endpoint was the cardiac death. And the patients who had viable and had revascularization on the viable myocardium had improved survival compared to the patient with non-viable myocardium by the butamine stress echocardiography. So this is a big evidence. Also, you have the Vienna trial that had investigated the viability guided invasive approach in patients with recent myocardial infarction, and it showed improvement in significant reduction in the future ischemic events if you are guided by viability. So if you're revascularizing a viable myocardium, this is going to have less ischemic events. To make the issue more complex, there is a STISH trial, and with a STISH sub-study, STISH sub-study viability study that had taken the patient from the STISH trial that had done myocardial viability test. They had done either by SPECT or either by the butamine stress echocardiography. This is a sub-study, either go with medical treatment or with CABG. And for the butamine echo, patient with viability were defined at those with 5 or more segment with abnormal resting systolic function, but manifest contractile reserve during the butamine administration. And this is a very tough definability of butamine stress echocardiography, and this is what makes the data a little bit contradictory in this trial, as we will see after that. And you can see here, there is no significant difference between the medical therapy or the CABG in patient with viability or without viability for the patients done the butamine stress echocardiography, but there was a trend to be better survival in patient with who has viability by the vitamin stress echocardiography respect, but this was not statistically significant. So the conclusion of this study that the study demonstrated a significant association between myocardial viability and outcome, but this association was not significant when subjected to multivariate analysis, and the study failed to demonstrate a significant interaction between myocardial viability and medical versus surgical treatment. But there are some critiques to the STESS trial that result that the viability testing may not be useful outcome assessment, but the trial has some limitation, including how viability was defined, as we had seen that they defined viability 5 or more segments, which is contradictory to what have been defined by the American Society of Echocardiography. It's 2 or more segments. Also, the defining viability based on limited number of segments with contractile reserve may be insufficient for the assessing the prognosis and benefit of revascularization. And finally, this is a comparison of the various techniques of predictive of recovery of regional function after revascularization, how the left ventricular ejection fraction will gonna improve after revascularization if you did an viability assessment before the test. As you can see, the Defamation echo is almost the most sensitive test after the Defamation MRI for detecting the recovery after the revascularization. As you can see from the table here, from the sensitivity and specificity, it's almost a very specific and very sensitive test for detecting the improvement of ejection fraction after revascularization if viability is detected by the echocardiography. So you may have added values to add the more sensitivity test, like using the LV contrast opacification, as Dr. Alexander would say in his lecture, or using the strain, the global and segmental for the increasing the sensitivity and specificity, which is still under investigation. So at the end, my conclusion are that the low dose Defamation stress echocardiography is a sensitive and specific test to assess myocardial viability. Low dose Defamation stress echocardiography is one of the most specific imaging modalities to predict recovery of LV function after revascularization. And the low dose Defamation stress echocardiography relies a lot on the operator experience. So practice, 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 and train. And thank you for your time.
Thank you, Ahmed. Really fantastic presentation. You mentioned all the basics and what is expected from the Defamation stress echocardiography regarding the assessment of viability. So to start, we have multiple questions on the chat board.
Chat box, okay.
On chat board, yes. Yeah, the first question from Dr. Alexander. If the patient is on beta blocker, how do you proceed with Defamation stress echo?
This is a very good question. If you are just planning to do a viability test, you don't need to stop the beta blocker. You do it on patient on beta blocker because you are not going to search for the chronotropic response. So you can do it safely on beta blockers. But if you are planning to do both the viability and the ischemia assessment, so are you planning to use higher doses, you should stop the beta blockers 48 hours before the test.
What I suggest doing is as well using longer intervals if the response is not enough, and if you just wait a little bit longer and maybe go to 15 or to 20, usually it works and it's fine. So I don't stop the beta blockers either.
Yes, as I have mentioned in the protocol that we are using for the viability, you are using a 5-stage interval for each stage, while in the ischemia you are using just the 3 minutes intervals. So exactly as you said, using longer intervals, I completely agree with you.
So a very good point regarding not to stop beta blocker while doing the vitamin for viability. So let's stop at this point and focus again on the difference between the vitamin stress echocardiography for ischemia and for viability assessment. Could you mention some points regarding the difference between both?
Yes, there is some differences in the technique you are using. If you are for the protocol itself, with the vitamin for the viability, you are using just the low dose. So the maximum you are reaching is 10, or maximum you are using 20 mic per kg per minute. But in the ischemia, you are going to 40, even 50, and using atropine up to 2 milligrams to achieve the target heart rate, which is 85% of the maximum age predicted heart rate, to know if there is ischemia or a change in the segmental motion abnormality or not. Another difference is you should stop the beta blockers 48 hours before the test. Another important test that you are using shorter stages. You are using stages, it's only 3 minutes. And the incidence of the arrhythmia is more common and the complications is more common when you are using the ischemia protocol rather than the viability protocol because of the higher doses that you're using of the butamine with its known arrhythmogenicity.
Again, thank you, Ahmed. Another question from Dr. Fanyak about the clinical decision on ischemic mitral regurgitation based on the low dose vitamin. I believe you mentioned that, but could we rehearse what we have mentioned in the presentation?
Okay, this is a very hot topic and it's always been a debate. If you have a grade 3 mitral regurgitation, would you, if you are planning to send this patient to do a CABG, would you do a mitral valve replacement or repair for this patient or not? And it has been found if you are using the butamine echocardiography and you noted during the test a reduction in the amount of mitral regurg to grade 2 or less, you may not need to do any mitral valve intervention in this patient because just the revascularization will make the mitral regurg regress. And this is more common if you have segmental motion abnormalities in the posterior and inferior wall rather than the anterior wall. So it's very important to ask this question. If you have a mitral regurg and you are questioning whether you do it or not, you should go for the butamine echocardiography. And fortunately, the butamine echocardiography is the only modality that offers you this dynamic assessment of the mitral regurg.
Again, very good answer, Ahmed. Let's ask you about when you find it's mandatory to use the butamine stress echocardiography as the tool for assessment of viability rather than the other imaging modalities. Is there a situation like that?
Yes, we have many situations like this. If you want to know the improvement of LV systolic function after the revascularization, if this is the main question. So if your patient is mainly presenting by heart failure symptoms and severely depressed systolic function, this will make you more confident that the systolic function will be improved. That's number one. Number two, if you have question about the dynamicity of the mitral regurgitation. Number three, if you have a patient with low flow, low gradient aortic stenosis, and you want to make sure that the aortic stenosis is truly severe to tackle this aortic valve during the surgery. So these are the three main situations that you can use this. Also, you may need it in other special situations. If you have a patient that is claustrophobic to the MRI, so you may go to this. If you have a patient that don't prefer to take radiation, like using the nuclear scanning, so you may use the echocardiography. The local experience itself, if you have a center that has very good experience in the place and they are experienced operators, this may have more sensitivity and specificity if you compare this to sending to unknown area to do the another tests. So these all should be kept in mind when you are choosing the modality for the using the assessment of the viability.
Thank you, Ahmed, again. We have a question from Dr. Bilal about the use of apical 3-chamber instead of parasternal long axis in the butamine echocardiography.
Yes.
Does it affect the timing?
Yes,
or
that's very important. Yes, that's very important. Usually, the standard views for the echocardiography, the butamine echocardiography, the low dose is the 4, 2, and parasternal short and long axis. But you may need to use the apical 3-chamber if you cannot see the parasternal long very much. The main target here is you should see all the myocardial segments, and this is very important. But you may need to use the apical 3-chamber view in the assessment of the ischemia, because with the increasing respiration and increasing the heart rate with the test, the parasternal long may be not that good, and you may rely on the apical 3-chamber. So make it short. If you can see all the myocardial segments from the 4-chamber, 2-chamber, parasternal long, and parasternal short for the viability assessment, you don't need an apical 3-chamber view. But if you cannot see the myocardial segments, you may add it to your protocol. I hope this answered your question.
Yes, it's a great answer, Ahmed.
Okay.
So we will use you for the maximum. And another question from Dr. Fanyak about if we have a patient with end-diastolic wall thickness of 6 millimeters or less,
yes,
do you still proceed with the butamine stress echocardiography for assessment of viability?
this is very important question. There are some parameters in the resting echocardiography that tells you that this myocardium is not viable. If you have a myocardial wall thickness less than 6, if you have an aneurysmal wall, if you have an endodiastolic volume more than twice the upper normal value, these are all parameters that telling you that this is not a viable myocardium, and you may not be encouraged to send this patient to do viability assessment. Also, the echogenicity of the myocardium itself is very important in the resting image. So if you have a myocardial wall that is aneurysmal and the thickness is 5 and it's bright and echogenic, most probably this is not a viable, and you should not go for viability test for this. But as we had said, if you don't have all these criteria, you may have your clinical judgment to see if you can send this patient or not.
So it's again a very good tip. So Dr. Bilal asked about the tips for having a good image quality. You know, you are moving quickly between the different views during deterministic cardiography.
Yes.
So how you optimize your image quality during
it starts always by good positioning of the patient. If you have a specific echo bed that have a window to be opened to let the patient be in the steep lateral position and with an opening in the front of the apex, you can get the apical views while the patient on the steep lateral position, that improve the images markedly. Always try to keep the patient in the same position during the whole test. Don't try to roll the patient on and out during the test, all the test, because you may lose the window you have got in the first place. And always start by a resting echocardiography and try to optimize your parameters as possible before going through the debutant stress test. That's my tips.
So this is a question from me, Ahmed. You mentioned that symptomatic severe aortic stenosis is a relative or a contraindication for debutant cardiography. However, we are using the debutant cardiography sometime in the patient with low flow, low gradient, and I believe many of them have severe aortic stenosis. So what do you think about that?
Yes, that's very important. If you have a diagnosis for surgery, okay, so there's no question you need here. Do we do this for the patient if you have a question about the severity of the asymptomatic, but you have a here on the test for this patient because he is already fulfilling the guidelines for going for the surgery. I think that makes sense, right?
I believe is the ejection fraction.
Yeah, you may be searching here. Yes, you may be searching here for surgery. Agree? This is for patient. So a symptomatic aortic stenosis with severely impaired systolic function. Would you send him for surgery if he don't have a contractile reserve? Yes, if this is the only etiology for his cardiomyopathy. But so this is maybe help you in just the stratification, but it will not change your decision for sending the patient for surgery. You agree?
Totally agree.
I have a different point of view here.
Okay.
I think this is misguided that we are looking for contractile reserve. What we are looking actually, when we have low gradient, and when the aortic stenosis looks severe on 2D, we actually have to exclude pseudo-severe stenosis. Yes. Point that we do. So we inject the dobutamine, and if the LV improves and the valve starts to move okay and the gradients do not increase, then this is pseudo-severe aortic stenosis and it doesn't need surgery. Otherwise, we either have severe stenosis or it's undetermined, because if we don't have contractile reserve, we cannot increase the gradients. But there is a study that shows that the patients with undetermined type of aortic stenosis do get improvement after surgery as well. So I agree. I just have a different point of view in my mind how to look at the test.
Yes, totally agree with you, Dr. Andrea.
Yes, Alexander, and I believe the cases when we don't have contractile reserve, we can use another imaging modality such as a CT scan for assessment of calcium score of the aortic valve. This can help us to
Yes.
predict the decision for the aortic valve placement. So I believe we a lot of information about the vitamin-based echocardiography, and back to Dr. Mohammed Zahran for the next presentation.
Thanks a lot, dear Karim. It was a really active discussion. I would like to thank Ahmed so much for this elegant presentation, and Alexander also for helping us with the questions and sharing his experience. I would like to introduce the international expert and imager, Dr. Alexander Nosikov, consultant of cardiovascular imaging and cardiology from Sofia, Bulgaria. Dr. Alexander will give us insights about the advanced echo techniques, including the deformation imaging and also including the contrast echo. So please, Dr. Alex, the floor is yours now.
Before I start with my lecture, there is a question there that's regarding the left hand, that the colleague finds scanning with left hand challenging.
Yes.
So my point of view on this is that you have to be able to scan with both hands, and there are different setups in different hospitals and different departments. And if all the colleagues are working on this setup, you cannot really go there and do another setup. And the second reason is when you go to ICU, sometimes the access to the patient is only from one side. So you have to be able to use both right and left hands, and you just need to do it. There's no other way. Now I'm moving to my lecture. I'll share my presentation. I want to start first with, it's a great honor for me to be invited here, so I thank you very much for that. I will speak about all the advanced imaging, not only about the echo. Just give me a second. Right. Do you see my presentation?
Yes, we see it clear.
Yes, it's very clear, Dr.
Excellent.
Alexander. Thank you so much.
I'm starting now then. These are my disclosures. I have no conflict of interest, no disclosures regarding to this lecture. And it's all the views in this presentation and during the talk are my own. Few words about myself to give you a little bit of background. I have 20 years of experience in imaging, in cardiac imaging and vascular imaging and functional testing. The first debutamine that I have done was in 2003. And at the time we had very, very difficult access to coronary angiography. So even the myocardial infarctions, most of them were thrombolized if they come in the proper time window. The rest were not thrombolized. We were assessing them usually at week 6 and doing debutamine to see if they have any ischemia, if they have any viability, and if they have ischemia, then we were sending them for coronary angiography. I'm currently working in a hospital, which is a SPECT center. So every Tuesday, we call 6 patients and we do them on a bicycle. We use technetium 99, we use MyoView, and we are, I believe, probably the largest cardiac nuclear center in Bulgaria. We do it consistently every single week. We do it. Sometimes we have slots on Wednesday. What is viability? Well, it's very simple. It's a potential of the segment to improve after revascularization. It's a very old concept. It was developed in the 70s, then it developed further in the 80s, and we have several modalities to assess it. There is no gold standard, although some people consider the PET to be the closest approximation to gold standard. It's extremely expensive, and I'll give you the prices at the end so you can compare the modalities. And unfortunately, it's not widely available. So as you already seen in the lecture of Dr. Ahmed Mohammed Farid, the standard low-dose debutamine stress echo is the most used modality worldwide. This is the document that we are supposed to use in Europe and to base our opinions on it. You already heard the data on stitch. this is the largest and only, and no other studies like that. So this is the only study where we have 10-year follow-up, and the endpoint is mortality. So there is a trend to some better mortality, but it was not significantly lower in the patients with viable myocardium. Here again, I have a different point of view, because when you have a complex procedure, for example, when you send the patient for opening a complex CTO, or when you have a high-risk patient where the perioperative risk is high, you have to assess viability. And if there is no viability, I prefer not to send these patients, because then they really things. So this is in my so usually, as I said, I wait 6 weeks, and then I reassess the patients. And if the patient had no reflow, they usually improve. Up to half of the patients, even if the vessel is opened and is opened early, they have no reflow and they get scars, unfortunately. Then we have the Hybernetic Myocardium, which is a chronically ischemic myocardium, or a myocardium which had repeated stunning. And then we have the myocardial scar. And I want to say here, and I will say it again later in the lecture, that things are not so simple. There are areas in the heart where we have mixed scars with a little bit of viable, a little bit of hybernetic myocardium, and a little bit of scarring. So it's not so simple. It's not so binary as it looks. Here you can see how the things progress to the chronic scar. You can see the different modalities, how do they work. And this is the classic image. This is how it looks on CMR. You see the myocardium is nude, so it turns black. Then the patient is, before that, the patient is injected with gadolinium, and we look where the gadolinium stays. And this white thing here is the scar, and here the patient has no scar. So these two situations are the best, when there is no scar or the scar is very limited, and these patients will improve after revascularization. Here the things are not so simple. When the scar is between 26 and 50, some patients do improve, some do not improve, some have very limited improvement. And above 50% of scarring, and in fully transmural scars, then even if you revasc this patient, there will be no improvement. So these patients, they do not benefit from being revascularized. Dr. Ahmed already talked about the standard 2D rest transthoracic parameters. So when you see something which is below 6 millimeters, and especially if it's an aneurysm or looks as an aneurysm, then we usually think that this is dead myocardium. And this is generally true, but there are some exceptions, and I have seen them on CMI imaging even. So some of the thin segments, when the patient is revascularized, they do improve. Now I'll continue with the defamation imaging. So probably it was in 2005 or something, there was an opinion and there was a belief that we can use post-systolic shortening as marker of viability. You can see it here. So here is the aortic valve closure, and then this is on tissue Doppler done on the mitral annulus. And now we don't use the tissue Doppler for that, so we can do it from the defamational imaging. And you see this segment here, the yellow segment, here is the aortic valve closure. There is post-systolic shortening. Unfortunately, the post-systolic shortening is not so good as it looks. This is a small study with 25 patients from 2008, but the patients are very well done in the studies with LG, and the post-systolic shortening was extremely common in the transmural infarction. But in non-transmural infarctions, there was no difference between the segments with or without contractile reserve. Then there is another study, a load occlusion model in anesthetized dogs, which concluded that post-systolic shortening is a non-specific feature of ischemic myocardium, and maybe that's entirely a passive mechanism. So I'm not sure we can really use this in our practice. The only thing that we can use from defamation imaging is when the strain becomes extremely low. Actually, the strain is with a minus, so when it becomes higher. So when the threshold of 4.5% is used for regional segment. I suggest, if you have the time and if your machine is good, when you do the bitumen stress testing, you always have an ECG attached and you always store the images. So I suggest, if you have the time, to try to run the speckle tracking and to do some GLS, because sometimes the GLS may show something that the eye does not catch. So it's a good idea to start practicing that, although it is still not the standard. The standard is just the bitumen stress testing. You know that there is significant amount of patients, 10 to 15 to 20%, where the image quality is indeed poor, very poor, either due to obesity or lung disease, or sometimes it happens in some very thin patients because the intercostal spaces are different and we cannot really get a good image. In such cases, it is suggested to use left ventricular obfuscation contrast. And there are some approaches to look at the infarct through the backscatter and the bubbles, but it's still a challenging technique, and it's not a standard technique, so I won't go into detail with that. Again, if you have a good machine, I suggest that you acquire some 3D images as well. And the 3D images, they give you several good things. First, if the apex is in the acquired image, within the acquired image, you can avoid foreshortening. You can do volumetry, and from 3D, the volumetry is much better than from the non-3D images. This is what we look on the bitumen. We look for the biphasic response if we do the higher dose. I usually prefer to stay low on the lower dose, and I try to reach my decision from this data if I don't need the data on ischemia. I don't like the high dose bitumen testing because there are quite a lot of adverse effects. So you can have arrhythmia, you can have AFib, you can have a blood pressure drop, you can have the patient with chest tightness, and you can even have myocardial infarction during the testing, or ischemia during the testing. But low dose bitumen is a good test, and most of the patients tolerate it very well. These are the alternatives. So you can do low dose exercise, which means that you exercise the patient at 25 or 50 watts. You can do it with or without contrast. The best is to do it on a supine bicycle, in my opinion. But if you don't have a supine bicycle, you can still do it. You can do some rest images, acquire the loops. Then you can put the patient for a few minutes on 25 or 50 watts, and then after the exercise, immediately exercise, apply some loops again and compare them. So it's still possible, but keep in mind that there is much less data on any other modality apart from the standard bitumen stress test. The same accounts with the dipyridamol, much less data. SPECT, very good technique. You have two modalities there. You can use thallium, you can use technetium. Thallium gives more radiation. The PET, as already said, is expensive. You can do CMR for late gadolinium enhancement. But there is one problem there, that you cannot assess ischemia with simple CMR. So if you need an assessment for ischemia, then you need to do CMR with the bitumen, where you can see the contractile reserve as well, and you can try to induce ischemia, and you can do perfusion, etc. And I'm starting with case examples. I'll try to be as much as practical as possible. Here I was lucky because I used some contrast and I had some contrast left. And this is a myocardial infarction, probably 24 hours or 36 hours after the LAD occlusion. We opened the vessel at hour 3 or 4. It was a young man, and I was seeing him for and anyway, I had some contrast, so I gave him the contrast. And you can see here a very large apical defect. This apical defect early after the infarction indicates microvascular obstruction. And you can see the same here on the CMR image. Instead of being bright here, bright and white, you see this black part. This is immediately after the infarction because the gadolinium cannot get there through the obstructed microvasculature. And this usually results large scars later. This is how the GLS bullae looks, and you can look at the regional strains, or you can use curves with regional deformation. And this image is a resting image. It indicates that the patient has some ischemia at rest or has had an infarct at rest. And you see at the apex, this part is nearly near to the threshold of 4.5. The patient has severe LUTS stenosis, and after the revasc, the patient improved. So this was all viable. The colleague, if he's doing his map, he's asking himself to simulate that they're riding a bicycle, and then he's doing the GLS at rest before that, and then he's doing after the stress. And here you can see such patients with clear ischemia in these regions. So this is another modification that potentially can be used. This is how a 3D looks. You can acquire a few beats. Here we have acquired one beat. The image quality is very good, and you can do volumetry. And it's very important to have non-foreshortened images. This image is foreshortened, that you saw. Now take a look at the non-foreshortened image, and you see there is an apical thrombus and probably some thinning at the apex. And then when the image is nice, and when you put some contrast, it even becomes nicer. The funny thing here is to be some contrast. And because this patient had cancer, we actually had a differential diagnosis of cardiac mets. But we put this patient on oral anticoagulation, and before that, low molecular weight heparin, and the mass dissolved. So it was a thrombus. When you use contrast, it's important to use the proper presets. On the left, you see how the contrast enters the right cavities and it enters the left cavities. And this is the proper preset. It comes, this was done on EPIC 7, and the MI is 0.3. Usually we use even lower MIs. MIs, the mechanical index, we use 0.1, 0.2. And here on the right, the mechanical index is 1.2 to 1, which is the standard mechanical index on transthoracic imaging, and you cannot really see the contrast, and the contrast is destroyed in the near fields. So you need to do the proper presets. There is one preset, so-called TSCAR preset, which uses a mechanical index of 0.47. And it is believed that when you use this mechanical index on lower gains, you can actually image the fibrosis and the scar in a very similar manner to the CMR on transthoracic echo. This is the preset on point G, and you can take a look how this looks in the loops. But this technique, the big problem with it is that it's undersensitive for the apical segments. And actually, the apical segments are one of the most important ones. You can see the scar here. It's very clearly seen. So it's a special preset that you can use. mistakes with opacification. If the contrast concentration is very high, there is a distal shadowing and distal attenuation, and you don't see anything distally. If you look on the, just a second, please. If you look on the right image, here is the problem with the focus. The focus has to be moved away so it doesn't destroy the bubbles, and this improves the image quality as well. Here again, the MI is improper, and this is the proper image there. Okay. How can we use the CMR? This is a patient that was referred to me. He went to a hospital due to heart failure because he had left ventricular systolic dysfunction. Coronary angiography was done, and they saw that he is with 3 vessel disease, diabetic, and he was referred for CABG. I saw this patient, but I thought that the infarct, the apical infarct, is transmural, and the right coronary artery and the circumflex could be done with stenting. So we decided with him that there is no point to put a bypass into this scar, and he had a lot of other problems. He had severe claudication, he was badly, very poorly controlled, and his heart failure was not very well controlled as well. So we decided to go on conservative side and to try to do the legs and the other arteries invasively with stenting. Unfortunately, this patient, about 7 or 8 months later, he died, but he didn't die from the heart. He actually died from gangrene of the leg. So remember that these patients have other diseases, and they may be more important than the heart, and then putting a bypass into a scar. This is how the scars look on CMR. This is fully transmural scar. And another example of nice LVO by Vladislav Kavalerchik. You see how nice is the image, extremely nice images, huge apical, septoapical aneurysm starting with thinning from the middle segments. Another example of SPECT. This was not viability study, it was ischemia study, but it's a very nice case. The patient had inferior myocardial infarction. Unfortunately, after being loaded with clopidogrel and aspirin, he had severe bleed from the stomach. The right coronary was opened before that. He had stenosis of LAD. After the stomach bleed, he suffered a stroke. I think he was even thrombolized. And he came to me with no neurological deficit, but the colleagues were sending him for surgery because the FFR was positive on the LAD, and they didn't want to put him on aspirin after the severe stomach bleed, so he was only on clopidogrel, and then stenting of the LAD being on clopidogrel is probably not a good option. So we did a SPECT, and you can see a clear inferior defect here and here, but there is no defect in the LAD region. This is just an apical artifact. It's not a real defect. So we decided that we won't do revascularization here, and the patient is fine and well for 2 or 3 years now. I'm going to conclusions now. So we can use different techniques, and these different techniques and modalities, they look at different pathophysiological problems in the dysfunctional myocardium. So it may happen that different techniques will give you different information or different results. And I'll show you such example. This is from the document of ACVI. Actually here we have a mismatch. This is a SPECT study and this is a PET study. And you see that the maps are different, and this indicates that there is viable myocardium. But if you look at the dobutamine, the dobutamine was negative and there was no contractile reserve in the dobutamine. So you may have discrepant results between different tests because they show different things. I think that especially before doing controls, you should always do some viability testing. I don't do routinely viability testing in all the myocardial infarctions. It depends on the results from the coronary angiogram and if they have multivessel disease. In three-vessel disease, when sometimes there are similar decisions to the one that I showed you, if you don't need to do the LAD, this is the frequent thing that happens. If you don't need to do the LAD, if you just need to do the right coronary and the circumflex, you can do stenting instead of coverage. So it works quite well. Dr. Ahmed already talked about the low flow aortic stenosis. You can look at prediction of CRT response. Usually, if you have huge scars, in particular, if you have a very, very big septal scar, over 50% of the septum, the patients do not respond. Most of the patients are non-responders. If you put the lead, the coronary sinus lead, in a scarred zone, again, most of the patients do not respond. Now it's not a big problem because we have the quadripolar leads and they can stimulate from wherever they want. And another nice example of CMR, this is viable, although it looks a bit thin compared to the basal septum, and it improves in 4 months. And here you see a transmural apical, the apex and the mid segments, everything is involved, thinned, nearly 100% LG, and 7 months post-revasc, nothing happens. So the pros and the cons of each technique, same as Dr. Ahmed, I suggest that you have to use the technique that you do regularly, the technique that you are most experienced with, because you are the best with what you do every day. Low dose dobutamine is the cheapest, the most widely available, but we have 2 problems there. First, it's operator dependent, and secondly, part of the patients have poor acoustic window. And then you have either to use contrast for ossification or go nuclear or do CMI-LG. If you have poor image quality, it doesn't matter if you do 3D acquisition or if you use strain and deformation. Your image has to be excellent. So if you do viability or if you do ischemia imaging, your image has to be perfect, and only then you can use 3D and GLS on top of the image. With the nuclear testing, yes, there is some radiation, but if you use technetium, there is much less radiation than with the thallium. And what we do is we do sequential imaging. We first do stress imaging. If the stress imaging is normal, then we don't do rest imaging, and this leads to much less radiation for the patients. And CMR without stress testing and perfusion imaging is not really suitable for the assessment of ischemia. So when you do just CMR-LG, what you see is just the scar. Why is that not done in my country? Because it needs special equipment. So you need special metal boxes where you put the perfusion pumps and special injectors, etc. And then you can do it. And I'll tell you a bit what are the prices and what is the reimbursement by the National Health Insurance System in Bulgaria. So the SPECT is 150 euros and it's 100% reimbursed. The reason for that is they reimburse the other SPECTs usually for oncology. And the National Health Insurance cannot reimburse the SPECT test for myocardium on the same price that the other tests. The dobutamine stress test and the contrast are not reimbursed, so the patient has to pay them, and usually it costs to the patient between 60 to 70 euros as an outpatient to do a dobutamine stress echo. The sonogy is another 60 euros, but it can probably be used on 2 or 3 patients. And there is no reimbursement for dobutamine stress echo and for the contrast. The CMR goes between 200 and 300 euros with the contrast, and we don't do dobutamine in Bulgaria, and there is no reimbursement. And why is there so little interest to reimburse these techniques? I'll give you an example. This is a patient with 2 CTOs, and you can, of the right coronary and of the circumflex, some marginal branch, and you can see there is fully transmural scar in the inferior septum and inferior wall, and over 50% scar infralaterally, and laterally it's probably 50-60% scar. And the patient was with left ventricular dysfunction and some mild heart failure. And he asked me, will he benefit from opening the CTOs? And I told him that I don't think so. So I sent him to an interventionalist for a second opinion who confirmed. But the guy was very young, and he found an interventional cardiologist who is specialized in occlusions, and he did him, and he opened the occlusions. And the LV improved, but I think it improved because this interventional cardiologist was very clever and he gave him Entresto. So I think the main reason for improvement was the Entresto. And I'm going to the end of my lecture. I want just to say that you have to remember that viability is not just black and white, viable, non-viable, it's a continuum. And when you do the testing, you have to remember that. Thanks for your attention. I'm finishing my lecture. Thank you.
Thank you so much, Dr. Alex, for this extraordinary presentation. We have some interesting questions from the audience. One of them is the use of GLS at peak stress, and Dr. Bilal cannot use the GLS stress because of the frame rate. This is a limiting parameter for them. So what's your advice for him if he wants to use the GLS as an evaluation of stress?
Well, I think you have to do, you can do GLS when you have a good machine. So when you have high class machine and when you have a patient with good image quality. And then anyway, you have the loops, and now on the good machines, there are some, you can go on the software and you can do the GLS very fast and the speckle tracking very fast. So there are semi-automated softwares that can do it. If your machine is not good, or if the image quality is not good, or if the frame rate is not good, or whatever is not good, why to bother with the GLS?
Yeah, I have to add something, Dr. Alexander. The frame rate for the global strain will not differ from the rest images than the peak images, because you are using the same settings of the machine. So if you're starting with a resting, if you have a frame rate over 50, you will have the same frame rate. Drawbacks with the higher heart rate that your ECG may not be good. So you may not have a good synchronization with the waves. So you are doing your best to get a good signal ECG, and from the start you get a good frame rate, and will stay with you the same.
Thank you.
Maybe if the frame rate is not good, you can try to decrease the image. So you can decrease probably the depth, and you can decrease the sector, and just keep the image on the region of interest, which is the LV when you do low dose dobutamine. So that's a good idea as well.
Yes.
Regarding the ECG, you can put the electrode points in different ways, trying to get the best voltage. You can invert the ECG, you can use the physio settings on the machine, but you have to try to use the lead with the highest vector on the ECG, with the highest amplitude.
Yes.
Another question is your experience in using 3D left ventricular assessment on viability.
My experience on what, sorry?
On the 3D echo, left ventricular assessment.
On 3D?
Yeah.
Right. When I was doing a lot of contrast studies, I used to have a 3D on the machine. So I was always acquiring one 3D loop. And then you can turn it, you can rotate it, you can do the volumes. But again, you need a good machine for that. I personally, I'm a 2D guy, and I usually manage to get good images on 2D, and I like them. But if you are prone to foreshorten the apex, for example, or to foreshorten the LV, this may solve your problem. because there are a lot of young doctors who go into echo. And in the beginning, before getting skilled and practiced, there is a lot of shortage. As I showed you the case in my presentation, which can be a big problem.
So let me ask you, Alexander. I believe you mentioned in the presentation that the speckle tracking and the use of strain rate of 4.5 might be an indicator of non-viable myocardium. You believe?
Yes.
I believe we don't still have a hard cut points for to depend on both speckle tracking and 3D assessment to say this ventricle is viable or not. And the job of speckle tracking and LV and 3D LV assessment would be the detection of difference of ejection fraction by follow-up, and especially if this difference is subtle. You agree on that, or?
This 4.5, it's for a regional segment. It's not for the whole ventricle.
Okay.
It's just one. It's for the disease segment in question. Because if you are with 4.5 or with 3, if your global longitudinal strain is like 3,
yes,
you will not be alive.
Yes.
So you understand the point. Okay.
Yeah, I have to add something in this entity. Using the strain for each segment, it's not that sensitive and it's not that reliable. You should use to depend on the global strain rather better if you want. If you want to use each segment by segment, and you see how it is improved, this will not lead you to something. It is very tedious, and it will not be very accurate, and had been tested before and it's not accurate. So you rely more on the global strain, not the regional strain of each segment.
I suggest a hybrid approach. When you are experienced, you know which zone is supplied by each vessel.
Yeah.
So you just look at the whole zone, and you look at 4 or 5 adjunct segments. And if you see a consistent picture in this zone,
yes, totally agree. So it's dealing with the zone, not each segment strain. That's very important. Yes, agreed.
Another very interesting question is when you would consider patient for revascularization despite no viability by low dobutamine echo, stress echo.
Well,
do you take that decision?
Well, in this situation, you need to prove viability or ischemia by another, or both, by another modality. This is what you have to do. So you go to alternative modality. Theoretically, I can do PET scan in my hospital, but I have huge problems with that because PET scan is 1,100 euros. I can't do them at the same time. I have problems with reimbursement, and I have to do the SPECT first. Then I have to wait for 1 month. It's because of reimbursement. It's not a clinical issue. Then I have to get the patient again. I need to do the PET. Then I need to put the maps. So I need to do something else. I need to prove that the patient has some kind of viability or ischemia. I have to do CMR. I don't see the point for someone to undergo through all the risks of revascularization procedure, especially if it is a CTO, and to revasculate vessel going into a scar. What's the point in that?
So let me ask a basic question, Alexander. We encounter patients with cardiomyopathy with unknown coronary anatomy. That might be to be a dilated versus ischemic cardiomyopathy. So is there a way to differentiate between these two categories using
to differentiate between ischemic and non-ischemic cardiomyopathy, one with scarring, I mean, is to do CMR with LG. So if the patient has scars, you can see if they're ischemic type or not ischemic type. But if it is stunt myocardium, then you will not see it on LG. I personally suggest that all patients with severe left ventricular dysfunction, if not contraindicated, have to be catheterized and have coronary angiography, and if necessary, they can have a biopsy or whatever. Some other things can be done on pressures or during the invasive study. So I very, very rarely do not send a patient with severe left ventricular dysfunction to undergo a coronary angiogram. I have only one such patient because he is very young and with very severe, he's with end-stage renal disease. So what's the point? He's with post-chemotherapy left ventricular dysfunction, age 25. If I send him for coronary angiogram or if I do whatever with contrast, he will not win anything. But all my other patients are cuffed.
So it is a very important point that you suggest that you should know the coronary anatomy before subjecting a patient to determine echocardiography for assessment of viability.
No, I wouldn't say I suggest that. I just believe that all patients with severe left ventricular dysfunction have to be need to have coronary angiogram. This is what I believe, and I do it.
I think, Alexander, that we can CT can help this issue. If you have any patient with severe impaired systolic function, so you can do a CT coronary angiography, which has a very high negative predictive value. So if you don't have thing in the coronary, you don't need to go to the invasive coronary angiography. So that may be a good alternative for this. But as you had said, I totally agree with you. Each severely impaired systolic function, the coronaries should be cleared out and the anatomy of the coronaries should be cleared out. Totally agree with you.
We have a problem again with CT because CT is not reimbursed, so the patient has to pay it out of his pocket, and it's usually 200 to 250 euros with a contrast, about 250, I believe. And the coronary angiogram is fully reimbursed 100%, so he will have it for free, not paying anything. But here I have to say that CT works best in patients below 60 years of age, because after 65, a lot of the patients have coronary calcifications, which make the image quality to be worse, and the risk for them of having significant coronary atherosclerosis is much higher. So CT, its best position is as a rule-out test in patients who are with low probability of coronary artery disease. Now they're working on CT very well, and they're doing very good function studies, so they can do a nice ejection fraction. And now there is research, I didn't mention that because you can't mention everything in the lecture, but there is research, if you have an ischemic region, if you have not an ischemic, a scarred region, there is usually late enhancement on CT images with a contrast. So you can get a glimpse even from the CT that this part of the myocardium is thin and scarred and with late enhancement.
Yes, it's called a CT perfusion, and I had a personal experience with this while I was in Johns Hopkins. We had worked in the team with Dr. Lima for it, but it has a relatively high radiation dose because you enter the patient twice, and the image quality, it's not always that good every time. So it's not well established yet, but it's on its way.
What's changed with the CT in the recent years is that now there are softwares that do FFR from the CT images, and they're widely used in UK, not in my country, but in UK they are widely used. So you can have a very, very good idea what is going on with the patient. If we speak about ischemia imaging, I prefer to have some kind of testing before sending the patient for coronary angiogram, because when the patient has a SPECT, for example, and we know where is the reversible defects, and then he goes to coronary angiogram and he's with 2 or 3 vessel disease, they know what to do. What's the problem on the patient? There are tricks with hybrid, with fusion imaging, where you can put the SPECT image, and on the SPECT image you can put the CT.
Yes.
Okay, there is a question about the vendor of the eScar system. from Dr. Viniak.
ISCA is not a vendor. It's just a preset that was developed by a group. So the doctor can look at the presentation. There is a link to the article, to the paper where the preset is mentioned, and probably he can find the preset settings in the supplementary material. But basically the setting is 0.47 for mechanical index and rather low gain. With this setting, you don't see so much the healthy myocardium. It looks kind of black, and you see the fibrotic myocardium white, similar to the LG on CMR. But again, as I told you, it doesn't work well. You don't see the, I believe that in viability assessment, probably the apex is one of the most important things that we look at, because usually the question is about LAD occlusions and if a thinned apex is dead or not.
Okay, another question is the use of viability in patient with STEMI, acute coronary syndrome, for in-hospital revascularization of non-infarct related arteries. Do you have these trends in your center to use viability to have a decision of revascularizing a non-infarct related artery?
You know what the guideline says? The guideline now says that based on several studies, the guideline says that we have to do complete revasc during the index hospitalization of acute coronary syndrome. I will take the liberty to disagree with that, and I will explain why. None of the studies that were used to support this decision were actually using the standard of care as it is. The standard of care is during the index hospitalization, you do the infarct-related vessel, and then in 6 weeks, you call the patient and you do stress imaging. And if the patient has an ischemic region, a large defect, for example, on SPECT, which is 10% or 15% reversible one, then you get the patient again and you do the non-infarct related artery. Why do I think that this approach is the most reasonable one? First, imagine a patient with LAD occlusion and huge anterior infarct, and you do the anterior infarct, you do the LAD, and then you see there is 85% stenosis on the right coronary artery. You go to the right coronary and you have complication, and the right coronary closes as well. What will happen with the patient? The patient will die. Second point, doing all the vessels, especially in 3-vessel disease, will get a lot of contrast to the patient, and then you will have a high risk of contrast-induced nephropathy. So I suggest that you just do it as it was done old school. You do the infarct-related artery, and then you call the patient in 5 or 6 weeks, and you do whatever stress imaging you can do best in your center.
Mm-hmm. I totally agree with this approach. This is reasonable and less risky to the patient. I totally agree with you, Alexander.
Yes, I think this is based on the reason more than the guidelines. So this is a logical thinking, but yes, we all do logical thinkings, but we cannot emphasize this as a routine because of the guidelines recommendations.
Of course, but the guidelines are there to guide us and not to restrict us. And
yes,
we are still clinicians, and we can discuss with the patients what we can do, and we can make our decisions, and the patients can make their informed decisions.
Totally agree.
I think we have a final question from Dr. Bilal Haytham. Would you like to convey the question, please?
Dr. Bilal said that do you exercise the SE to judge the success of angioplasty?
Let's say that I know this question. So Alex and Ahmed, also let me share your experience here. So you did a patient like a CTO or something, and then after several months you want to see without performing a control angiography again, and you want to see the success of the procedure. So you refer the patient for an exercise stress echo, for example. So is this a standard or routine, or sometimes on patient by patient basis, that you offer the patient a stress echo? Maybe this is what we call a symptom limited exercise test or something like this.
Here, it depends if the patient has resting motion abnormalities, zone which is below the CTO and supplied by the CTO. The first thing that you look is you look if the patient has improved. Because I keep an electronic archive, a digital archive, so I can look 6 months back, look at the echo and compare it with the echo today. So if the patient has improved in terms of all motion, yes, then the procedure is successful. Regarding the stress echo, I prefer the exercise echo because it's more physiological. As said, the best is to have supine bicycle, but if you don't have a supine bicycle, you can still do it. But if the patient has no symptoms, or if the patient has improvement of symptoms and is asymptomatic or nearly asymptomatic, I may not do it.
Yes, I think this should be tailored in each case. It's not a routine to do it. If you have the patient that don't have any symptoms after the revascularization, his function capacity is improved, his echo is improved, or the akinetic segment have become hypokinetic or even retained to normal, no new wall motion abnormalities, I wouldn't send the patient for an exercise test. But if the patient had new symptoms, persistent chest pain, then I would do it to know if this angio is competent or not. So I think this should be tailored in patient based, not in every patient. Yes.
This is a wonderful real life and also wise answer, because this is what we do. And sometimes, let me say that because maybe I work interventional more and maybe CTOs and complex, sometimes I choose for a particular patient to do a control angio because I want to know the anatomy, because I want to know the size of the vessel. I feel that the stent is undersized, it may need to be overexpanded, something anatomical. Sometimes the patient gives me a complaint that does not go with the echo. The echo shows a good ejection fraction, but the patient is still complaining of chest pain. So maybe I would like to exercise this particular patient to give him and give myself the confidence that he's okay, or maybe reveal a problem that has not been seen adequately in the clinical examination. This is very wise. I would like to finalize by one question, because Alex gave me an inspiration by the final CTO case that was also the patient improved because of the advanced heart failure medications. And those 2020 and 2021 patients are lucky to have the SGLT2 blockers available and to have the valsartan neprilysin combination also for heart failure, and the patient improves. We don't know he improves because of revascularization or he improves because of the drugs, but at the end of the day the patient is fine, so the doctor is fine. So Alex, usually, because now
actually we do know.
Yeah, we do know. Yeah.
Actually, we do know, because the thin segments, which were 5 millimeters, they remain 5 millimeters.
They remain 5 millimeters.
And they remain akinetic. So the other part, the LV, starts to move better, which is not supplied by the CTOs, it is supplied by the LAD.
By another artery.
So we know the answer to the question.
Yes. Okay, so here, yes, you revealed half of the question that I was going to ask you. In the RCA and the circumflex, sometimes we are very confident to say that, okay, this is a non-viable area. I will not go with costly equipment, long procedure, fatigue for the operator and the patient to open a right corner or a circumflex. But let me say, from the interventionalist point of view, a proximal LED, or a paraosteal LED. It may be seen sometimes, yes, very few cases, but sometimes we encounter this. We see a non-viable LED. Do you really, do you really trust here that you can leave the LED totally occluded and just go for either medical therapy or revascularizing the RCA and the LCX? Or sometimes if it will take some effort and money to open this LED, we can open it, because I like so much the slide about viability is not black and white. It's rather something gray between. Maybe some technique has a better opportunity to discover viable cells than other technique. Maybe we do not have the 100% technique yet. I want to hear like something like an expert opinion, because I know you have been using imaging for more than 20 years. So I would like to hear from you. And also I would like to hear from Ahmed, because I know he spent some time in Johns Hopkins and maybe he encountered this kind of conversations between the staff there.
Yes.
I have three CTOs of LED in the last 1 or 2 weeks, which were referred to me for exactly this question, what to do with them. So they went to a center which is not very experienced in opening CTOs, and it's not very clear if they're symptomatic now, if there is reversible, if there is ischemia, if there is viability. Every patient is different. So the first patient had huge aneurysm, and he has QRS from V1 to V4, and he has ST elevation which stays, and the infarct is old, it's probably from November, and the segments are thin. So I will do SPECT, but I bet, even from now, I bet 99% that this will be just aneurysm, and we'll just leave it this way. The second patient is completely different. Heavy smoker, 60-year-old, and has a very, very small akinetic segment in the distal apex. All rest is preserved. So I have to do a proper stress imaging test on him. And if he has ischemia, we have to try to open the CTO. We don't have any other choice. The third patient that I saw is somewhere in between the first and the second. So I'll just probably do SPECT on all these patients. And the thing that I like with the SPECT is that we don't have any problems with the image quality. It's not operator dependent. I have stress ejection fraction, I have rest ejection fraction, I have the wall motion, and I have the perfusion, all on maps and very objective, not subjective. So I'll do SPECT on all them, and then I'll decide. It's a little bit more tricky with diabetic patients because you cannot rely on symptoms with them. I find this problematic, so I try to do stress imaging if I think they have ischemia or viability or whatever. Thank you.
In my opinion, it's a patient-to-patient decision. Let me tell you, if you have a young patient, like he have 35 years old or 40 years old, and he have a total occlusion of proximal LED, even with the non-viability, I will give him the chance by revascularizing this patient to improve the left ventricle even later on, and to avoid developing ventricular arrhythmias later on. So if you have a young patient with no comorbidities and the lesion will not be very problematic and will not expose him to a lot of contrast, and this, I would do it. And also, you should reconsider the assessment of the viability. So if you have it, it's non-viable by a less sensitive modality, right? If you use the SPECT or you have had using the vitamin stress echography, you may need to send the patient to a higher level to be pretty confident that it's not viable. You can send him to do a PET, you can send him to do an MRI, just to search for any viability in this patient. So I think this should be tailored in each individual patient according to your assessment, how much he will get benefit from this. So if I told you, if this patient have a persistent ventricular arrhythmia, do you have any modalities in your hand apart from revascularization, even if you don't have a scar or non-viable myocardium? I think you will do a revascularization for him just to stop the recurrent ventricular arrhythmia from this patient.
Thank you so much, Ahmed, for highlighting this, and thank you so much, Alexander, also, because it's always about the wise doctor taking the wise decision, the wise doctor who can tailor the decision according to his patient. As Dr. Alexander highlighted, he had 3 examples for 3 patients presented by CTOs of the LAD, but the 3 patients have a totally different scenarios from each other. So this is really important to show. Ahmed showed us maybe this patient will have an arrhythmia, and then if you go to the guidelines of treatment of recurrent VTAC, you will see that the options are number 1, revascularization, number 2, ablation, number 3, ICD implantation, and so on and so on. So actually, the patient will also move to a different chapter in the guidelines, and he will be treated according to this chapter. Finally, I would like to conclude this webinar by thanking so much Dr. Ahmed Farid, consultant and lecturer of cardiology from Suez Canal University, for offering us his time and effort. And I would like to extremely thank, and I'm so happy and proud to meet Dr. Alexander virtually, Dr. Alexander Nosikov, consultant of cardiology and cardiovascular imaging from Sofia, Bulgaria, and an international figure. I am really happy that he allowed to share with us tonight his ideas, thoughts, and hopefully this is not the last time. Many webinars will come to follow, and maybe after this COVID era, one time we can meet each other live and physically instead of virtually. I would like to thank Dr. Haitham Suleiman and Dr. Karim Mahmoud, Dr. Ahmed Saeed, Dr. Abdurrahman, and all our attendees tonight for sharing with us their experience. And hopefully we will meet in the second part of this webinar discussing the rest of this consensus paper. Thank you so much and good night.